So I'm going to show you how to do a kind of a quickie knee exam, relatively slow. But you could do this in 5 minutes if you become proficient in it. And those of you who are doing the workshops later, we're going to follow a very similar, similar format where we kind of do seeing what the patient looks like when they're standing in the office. Hopefully they can stand. And then sitting down, and then sitting off the edge of the bed. I'm going to show you how to do a Lachman's test for an ACL and check the ligaments with the patient sitting over the edge of the bed. It's a lot easier to get them to relax. It's also easier for patients who are a little on the heavy side because if you have them lying down and you're trying to test the ligaments, there's a lot of wiggle. People guard more because they think they have to help you lift their leg up. So hopefully you guys will be able to apply this later on today. All right, so our lovely model is going to demonstrate some of the things that we do when someone's standing. Obviously, for some of these tests, when someone comes in with an acute injury into your office, you're going to need to modify them. Otherwise, you're going to get a patient complaint filed against you if you try to flex their knee up to 140 degrees when they come in with a stiff, swollen knee. They're not going to like that. So some of the things you'll need to cut out. So common sense is the guide. Sometimes our residents, I'm like, come on, think. Like if the patient can only bend their knee to 45 degrees, you don't want to try to do a MacMurray's exam where you're bending them up to 140 because they're going to scream at you. So some of these things, they come in on crutches and it's painful to weight bear. You're not going to check their gait. You're just going to, okay, they're on crutches. They can't really weight bear. Hopefully you've gotten x-rays at this time point too. So anyway, Christina is going to, she comes in, patient, maybe it's a long-standing complaint. We want to see how they're walking. Dr. Feely was talking about arthritis. Maybe she's 55 and she has some arthritis. We're going to assess her gait and see if she's limping. So normal gait, knees over the foot. Turn around, so stay in one place so you can see. Okay, all right. Now we're going to show you a common thing when someone has arthritis, especially in the medial compartment. They sometimes can develop a varus thrust that you might notice. If you watch Dr. Feely leave, he has one. He's in denial about it, but okay. Let's see if I can see. So I can do it. I'll do it a little bit. Just do mine, okay. So it's like this. Sometimes people, you'll see the leg bow out like they're a cowboy. Okay, all right. So then the other things you can do, so that's a sign of medial compartment arthritis, and people get, because their joint space closes down medially, they get some laxity in the lateral side of their knee, and their lateral collateral ligament's a little incompetent, so they get this kind of intermittent kind of cowboy type of thing that looks like they could ride in the rodeo. The other things I do in this position, if the patient has decent range of motion, maybe they come in, they think maybe you're thinking maybe they have a chronic meniscus tear or something like that. I'll have them do a deep squat. And when I mean squat, I don't mean this. I mean like try to get them to go butt to floor. So older patients, they're going to have trouble with this. But a younger patient, they may be able to get down butt to floor. So literally butt to floor. So if I have you file this away, the criteria for thinking about ordering an MRI for a meniscus tear, because it's one of the more common things that you might see in the office. You want to have normal x-rays. We don't do meniscectomies on people who are bone-on-bone arthritic. There's lots of studies that Dr. Feely talked about that people don't do well on that. But maybe someone has pretty decent looking x-rays and you're thinking, well, maybe twisting injury, maybe they tore their meniscus, they have some chronic pain, medial or lateral side. First test is a deep squat test, and so you're looking for pain on the sides, one of the sides, not in the front, because if someone has arthritis behind their kneecap or patellofemoral pain, they're going to point to the front of the knee. So pain with a deep squat, no, double squat. Okay, here, or on the outside as they push off to come back up, because you're compressing the meniscus, so push off, come back up, as you're rising back up, not in the front. Stuff in the front is patellofemoral until proven otherwise. So, second test, meniscus test, so you got one, is Thessaly test. So basically, this is kind of test patients' balance also, because you can see how bad their core strength is. You have them bend, and then you have them twist side to side, not through the waist. I have so many people that can't do this. They're like this, and I'm like, no, you're not even turning your knee. So it's a compression rotation. A lot of these meniscus tests are designed to compress the tear, pull it, and you check to see if they have joint line tenderness or pain wherever you're suspecting the meniscus tear is. They're pretty accurate a lot of times for medial meniscus tears especially. So, and if your patient has some balance issues, you can like have them hold your leg. So this is a Thessaly's test. Can you advance to Thessaly's on the thing? That's a squat. And the next one, okay. Okay. So that's my former scribe doing it. She was really good core stability. So, so it's twisting in and out, not this. It's not chubby checker. So, all right, so that's the second test. The third and fourth tests, I'll show you when Kristen's lying down later, which is joint line tenderness, MacMurray's test. The other one that's common, kind of like the fifth test I talk about, is patients oftentimes complain that they have pain lying on their side with their knees together, so they sleep with a pillow between their knees. So that's kind of my fifth soft test. If a patient has 3 out of 4 positive signs on exam, I order an MRI, and their x-rays are pretty decent. So, all right, and the last test on this one is kind of more of a return to play test, or if someone has patellofemoral pain and they have pain with running, I'm checking for core stability. It's a simple test called a single leg squat. It's kind of like a pistol squat. Basically, the patient puts their leg out in front, and you have them do kind of a 45-degree squat like that. And I'm checking for, the left patient on the left has a really bad single leg squat, not you. But if you notice Kristen, I was teasing her earlier, she's got a little bit more valgus collapse on the left side, so she needs to work on her glute strength. So a lot of times sometimes they're shaky in their quad and they're weak. That's a post-op thing. Like they're just like blah, 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 jello leg. But sometimes people have glute weakness and their hip collapses and then their knee collapses in, like the patient on the left in the video. My scribe has an awesome single leg squat because she does like yoga, all these things. So, all right, so those are all the tests that we do standing. Next things are lying down. So let me have you lie all the way down. Where are you going to go? Okay. Okay. All right. So excuse my back. Actually, I think it'd be better if you were there because I'm going to block all these people here. So, okay. So first thing I always assess, because I think I'm like obsessed about the patella, I always check swelling and the warmth in the knee. If you're not sure how to evaluate for swelling, one of the best tests to see how pissy a knee is just put your hand on it and compare it to the other side. Patients oftentimes have no concept of how warm their knee is, and if you have them do this, they're like, oh yeah. So the other way you can tell swelling, obviously a huge effusion, a lot of swelling, the knee's going to look like a grapefruit, and you can't make the kneecap out. That's the easiest way to tell if someone has a decent effusion. The subtler things, sometimes not so easy to pick out, but most knees, should be a little more light in here. Most knees, if you look at your knee straight, you have a little dimple to the inside of your kneecap, right here. That is the first place that definition disappears when you have swelling. So it's like a mild effusion if the dimple disappears. Moderate effusion is like this, and moderate effusions or large effusions that happen immediately give you the impression that there's blood in the joint. It probably happened due to a trauma, and there's only a few things that cause like big effusions within a few hours after an injury, and that really narrows down your diagnosis. It's not going to be arthritis. It's going to be like ACL tear, maybe an acute bucket handle meniscus tear because that sometimes causes bleeding. Patella dislocation tears a little blood vessel that goes to the retinaculum, bleeding within a few hours. Tendon ruptures also cause bleeding, and sometimes if someone has an osteochondral defect that they shear off, that causes bleeding in the bone and they get swelling within a few hours. Meniscus tears, the standard ones, it's kind of overnight swelling. And then there's the kind of mild overnight swelling when someone overdoes it because they have patellofemoral pain or they have some arthritis. So I assess for swelling. Next thing I do, if I'm thinking about a patella dislocation, is I'll check the mobility of the patella. Most people, this is why I have people lie down, is if they're guarding and they're sitting up watching you, they'll tighten your quad and you won't be able to assess patella mobility. So we have them lie down. If they pick their head up, I'll say, put your head down just for a second, just wait, because sit up for a second. If Kristen sits up, she tightens her quad, and I can't check how mobile her kneecap is. So, but for patella mobility, if someone dislocates, 99% of the population will dislocate laterally. The medial patellofemoral ligament gets torn off the bone or in the mid-substance, and most people dislocate laterally. So you want to check mobility. Most people maybe move 50% of the width medial and lateral if their medial retinaculum is intact. If you have someone that's especially a chronic dislocator, you feel like you can run out of the room with a kneecap laterally. So it's kind of almost sickening, but there's just a huge amount of mobility. Again, you want to check side to side because you do have patients, Ehlers-Danlos, or people are just loosey-goosey in general, that they may have a very mobile patella, young girls, because they haven't kind of matured skeletally yet. But you want to check that mobility. If you feel like the translation is excessive laterally versus medially, then you should suspect, and they have a big swollen effusion, and they felt their knee pop, then you want to suspect a patella dislocation. Sometimes we have the apprehension test where you do this and the patient's like apprehensive that you're going to dislocate their patella, especially if they have repetitive dislocations. They try to swat your hand away. You can go forward a couple of slides, I think, or maybe not. Okay, I'm going to get to that. That's good. So you want to check mobility of the patella. Obviously, you're going to, like, if this is something that the patient doesn't have a big effusion and you're thinking they twisted their knee and they have joint line tenderness, you're thinking about meniscus tears, you can skip that test. Okay, next thing, say someone comes in, acute injury, big swollen knee, they're walking down the stairs of a jetliner and they trip and fall, and now they're having trouble, really a lot of trouble walking without crutches. You want to check for maybe a quad tendon tear or a patellar tendon tear. Bill Clinton, walking down the stairs of his airplane, tripped and fell towards quad tendon. One of the tests you can do for checking if you're suspecting a tendon rupture, big swollen knee, is you can check for tenderness. The most common place that a tendon tears off the patella is either quad tendon from the patella is up at the top, patellar tendon from the patella is just below the patella. So you want to check for that tenderness. Sometimes if you bend the knee up, you might actually feel a palpable gap between those two things. The best test for you is have the patient lock their leg out and try to do a straight leg raise, like that. If they are unable to do that, or if they're unable to you bend their knee up a little bit and ask them to extend it straight against gravity, then based on the mechanism and the tenderness, you should get them in to see someone right away. That's something that we need to see within a few days after the injury. You could order an MRI if you can get it quickly, but if you're not able to, just refer to an orthopod based on the mechanism and this exam. I was going to say a lag would be if I asked Kristen to lift her leg up as a unit and she just like have this trail. A lag is like this, and they're not able to lift it up just like that. You're doing it too well. Like this, okay? And she's never able to straighten it out. I lift her leg up like this and she's not able to extend it without my help. And again, if you can also feel for a gap too, or where they have tenderness. So that's an acute injury, something you want to refer right away. All right, last thing on here is the third meniscal test, we want to check for joint line tenderness. In your small groups with me, I'm going to have you find that joint line so that you're comfortable with it. This is where you got to be like gnarly with your thumb and really get your fingers in here to see if patients have tenderness. So you feel, just like in the picture there, you want to find the bottom of your kneecap. And you guys can do this subtly under the table. You're not being weird, okay? Bend your knee up to 90 degrees. Find the very bottom of your kneecap. It's a nice bony landmark, okay? If you go just below that, that's patellar tendon. If you go over to the lateral side first. If you go away from the patellar tendon, find the edge of the patellar tendon, that's your anterior medial joint line. If you can find that spot between the bone of the femur and the bone of the tibia, there's a soft spot there, that's your anterior joint line on the lateral side. It's also our arthroscopic portal. So if you got that, then you can do a knee scope, okay? So that soft spot, you go a little bit behind that, a little posterior on the lateral side of the knee. You come to a structure and there's the front edge of it that you can roll over. What do you think that is? A lot of whispering. On the joint line between the bones. I hear like tibial condyle. No, I always get everybody on this. Okay, what's in front of that people always come in and complain that it hurts when they run? IT band, right. So the first thing you run into is the iliotibial band. If you can roll over, it's about this wide on your leg. So that crosses laterally. You go a little further back, then you find soft spot again, and then you come into another structure that goes from here to the fibula. What's that? That's the lateral collateral ligament or the fibular collateral ligament. You should be able to feel it. It almost feels like about the width of a pencil. If you cross your legs over, you'll feel it even more. So that's rarely torn in an isolated fashion. Every once in a while I get someone that's like overly aggressive at yoga and doing this thing that's not flexible, and they tweak it, or wrestlers. But lateral collateral ligament injury isolated is super rare. So that's your lateral collateral ligament. If you go behind that further, you're going to get lateral meniscus. That's a good place to check for joint line tenderness. It's also a place sometimes when people tear their ACL that they complain of achiness because they get a bone bruise back there. So if someone says they were skiing and they felt a pop and they twisted their knee and they have some achiness at night over here, I'm already thinking ACL. Okay, so that's posterolateral joint line where the meniscus is. And then I'll get underneath the hamstrings and feel posterolateral even further. And those are like meniscus tenderness areas. Okay, so then we go to the medial side. Okay, go back to your kneecap and find the medial edge of your patellar tendon. And you can do this even with heavier people. You bend the knee up a little bit more, it'll bring the structures out a little bit more. So anterior medial joint line. Pain there and on the anterolateral part is patellofemoral until proven otherwise. I wouldn't call these tenderness areas meniscus. It's very rare to have a symptomatic meniscus tear in the front. So joint line, if you hit hard bone and it's not soft and mushy, then you're like either on the condyle above or the tibial plateau below. So make sure you get back to that soft spot. It's about a centimeter in between them. Then you come back to a structure that's going north and south this way that's about this wide. What's that? There you go, MCL. Somebody knows all the answers back there. They're cheating. Okay, so meniscus, MCL. So your MCL goes from your medial femoral condyle across the joint line to your tibial plateau. And it's pretty long. It goes from like here to here. Hamstrings, the medial hamstrings are coming down below you. Sometimes you can feel those if you're thin. They're kind of going this way, and you feel these little lumpy, bumpy things, kind of like penna pasta coming over this way. Okay, I think I must be hungry. I have a lot of food references. And then back of the MCL, and then meniscus again. So that's a joint line place for checking for tenderness for the medial meniscus. And then medial hamstrings, and then get back underneath them to the posterior medial joint line. So that's posterior medial meniscus. Most meniscus tears that are symptomatic are in the body, kind of midway, and in the posterior horn. Again, you see an anterior horn tear on an MRI, no biggie, because usually people don't have symptoms from them. So, all right, so then that's the third meniscus test. The last one is MacMurray's test. You want to do that well. Can you forward to MacMurray's? I think it's like a few. One more. Okay. One more after that. We'll just keep doing that one. Okay. So the key with this is you're not going to be able to do a MacMurray's on someone with an acute knee that's stiff, because for this to be effective, you notice that's you in the video too, like getting tested twice at the same time. You want to flex the knee up enough. So I don't want to do this if someone shows me actively they can only bend to here. I'm not going to go like this, because then they're just going to take a swing at me probably. So one of the things that I neglected at the very beginning, well, we can do it now, is I want to see what Kristen's range of motion is. So I check her other side first, because hopefully she has a normal one. I want to check how much she hyperextends and how much she can bend up on her own. So flex your knee up. So she's very flexible. She's like 0 to 140 degrees. She doesn't hyperextend. She doesn't lack extension. If someone has a bucket handle, maybe they can only straighten out to here, and they try to straighten out more. They have pain where the meniscus is flipped in the front. But if they have an acute knee, maybe she comes in, she can only straighten out to here, and she can only bend to like there, and it's painful. So I'm not going to go and do this because she's not going to like it. So we check our motion, we compare side to side. An ACL is going to be stiff also, but they hopefully with some coaching can get fully straight. So, all right, so we've confirmed that she has decent range of motion, so now we can do a MacMurray's test without her being upset with me. So I'm going to bend the knee up, and I want to flex it up enough so that I'm compressing the meniscus and torquing on it. I usually put my fingers on the joint line, and then I do a varus stress. I'm swinging the foot in kind of like a pendulum, and then I'll go out, just like in the video, to valgus stress to close down the lateral joint line. So I'm kind of checking medial meniscus, lateral meniscus. So if Kristen says it hurts over here on the joint line where we palpated before, or maybe sometimes you feel a click, that's not super common. A lot of times I just go by pain. Then that's a positive MacMurray's for a medial meniscus tear. If she says when I do this that she's got pain on the lateral joint line, then I'm suspecting a lateral meniscus tear. What happens if I do this and she says she feels a pop or some discomfort on the lateral joint line? What do you think? Positive MacMurray's? IT band snapping. Again, the cheater. So IT band. A lot of times it'll snap over the lateral joint line if they're tight. I'm just joking, as you can tell. I appreciate that. Other than the whispers, I like someone shouting out the answer. Okay, so it's lateral, IT band. Not usually lateral collateral ligament. Okay. What about when we do the other way, valgus, and patients have discomfort on the medial side, in the middle? Positive MacMurray's? MCL. So this will stress the medial collateral ligament. We'll get to the ligaments in a second. So pay attention to, think about like what you're compressing and what you're stressing. So don't just, if she says she's got medial joint line tenderness when we're doing this, it's not a medial meniscus tear. We're actually opening up that space, so she shouldn't have tenderness. So MCL. So that's MacMurray. So we'd go that 3 out of 4 test, and then we're thinking about ordering an MRI. Last test I do supine. We do a pivot shift test, but that's pretty hard to do on someone with a normal knee or someone that's guarding. That's something oftentimes we do in the operating room. Sometimes people with a chronic ACL tear, we can get them to relax enough to get a pivot shift, but it's also very hard to demonstrate and for you guys to see a positive pivot shift, especially in a normal knee. So we'll talk about that in small groups. The last thing I do supine after that is a PCL test, because we want to test the PCL at 90 degrees of flexion. So a lot of times we learn in medical school, do an anterior drawer for an ACL. The problem is that when you do an anterior drawer test, if the PCL is torn and the knees sag back, when you pull forward, you're going to think, oh, the ACL must be torn. So I only do a test of the knee ligaments for a PCL injury at 90 degrees. Lachman's is at 30 degrees. So I guess I'll do this one here. Put the knee at 90. I run my finger up the medial side of the knee. And if you do this to yourself, unless you have a PCL injury, you should notice that as you come up the medial tibial plateau, across the joint line, your finger goes back about a centimeter. Go forward. So even I have this in here, we don't do it. Oops. Forget it. So your finger comes up, goes back, and then the medial femoral condyle. So that should be your normal orientation. If someone has a PCL injury, those oftentimes are flush. So I pull the tibia forward and then push back. And if I feel about a centimeter of motion, then it's probably a grade 2 or possibly even a grade 3 PCL. Grade 1s, we don't even really do anything with clinically, but a grade 2 sometimes will brace people if it's an acute injury. Grade 3 sometimes need reconstruction. A 2 will, if you pull the tibia forward and push back, the tibia will be flush with the femur. A grade 3, oftentimes when you push back, the tibia will go behind the femur, the medial femoral condyle a little bit. So let's see if I can find the video so you can see it. Somehow I got it out of order here. So you see a sag. If you lift the leg up like this, the tibias sag back compared to the other knee. That's the finger. That's a posterior sag. And this is a patient of mine that has a PCL injury. So pull the tibia forward. You can see almost that the tibia is sitting a little bit behind the medial femoral condyle when I push back. So, okay, So I'm going to go back to the, okay, pivot shift test. Hard to learn to do, but basically the pivot shift, the mechanism is when the ACL is intact, the tibia and the femur will go along with each other and stay aligned when you flex the knee up and you put a valgus stress. It's a nice, smooth type of progression. When the ACL is torn, the tibia sits a little bit anterior to the femur when you lift the leg up like this. And as we bend the knee up and do a little bit of valgus, IT band coming over here, tightens up and clunks the tibia back to the normal orientation with the femur. So it's a really kind of a feel thing. You may feel the leg shift as you flex the knee up to about 30 degrees as the IT band tightens and the tibia reduces in a abnormal knee. But this patient here, you can actually see because he has a little bit of a collagen disorder, so you can really appreciate what's happening. You see how the tibia like clunks back? So that's a pivot clunk. It's also asleep too, so that helps. So, but I could do that in the office because it's a chronic ACL injury. Okay, so we'll go back to ACL. Okay, so the Lachman's test, the standard way you're taught is to pick the leg up, bend the knee to 30 degrees, hold the femur with your one hand and hold it still, and then do anterior drawer just like that. And that's a positive Lachman's there. Problem is that most people, especially for me, and I have pretty decent sized hands, people guard when you do this. They're holding their leg up. They think they have to help you, especially like a football player that's twice my size. And they're firing their hamstrings and their quads, so then there's no translation because everything is tight. So one of the best tricks I've learned is to do a drop Lachman's where the patient sits on the edge of the table. You get them to relax more. You can actually feel that they're relaxed before you do the test. So let me have you sit on the end. And this is also helpful for when you're doing, come over this way a little bit more. It's also helpful for doing the collateral ligament testing too, because you can quickly change from one knee to the other. So, so I have the patient sit with their knees right at the edge of the table. Go back. And I tell them to sit back like you're sitting on a park bench. For some reason, everybody knows what that means. I don't know why that is. So lean back like this, okay? That relaxes them. I always do the normal leg first so they realize this isn't gonna hurt. I think I've only had one person hurt when I did a Lachman's that had like a bucket handle that displaced. It actually shocked me because I've never had that happen before. But most people can relax. So I'm gonna do normal leg first. Just for the sake of everybody being able to see, I'm just going to pretend this is normal and abnormal leg. So usually what I do is I check collateral ligaments first. So I'm going to bend the knee down a little bit, just to 20 degrees. The more you bend the knee down, the more laxity you're going to have. So you don't want to do MCL and LCL down here. You're going to have all this wiggle. You just want to unlock the knee and the bony constraints, and then for MCL, we're going to do a valgus stress. So I put my hand on the outside of the knee, put my other hand to the inside of the ankle, and it relaxes. And I can also, when I'm doing this, make sure the patient's relaxed because you'll feel them tense up with their hamstrings. So I got my hand behind here and going, Kristen, relax. So school teachers and lawyers can't relax, and accountants usually. Okay, so I'm valgusing, and I'm feeling over here, and I'm looking over here. So grade 1, there'll be no motion, but there may be pain. They feel pain over the MCL. Grade 2, you may see a little bit of a dimple, but you feel an endpoint. There are actually numbers associated with this, but I go more by what it looks like and what it feels like. So a little bit of dimpling, and then a grade 3, you feel like you can run out of the room with the leg. So it's almost sickening because it opens up so much because the MCL is completely torn. So then we switch legs. I'll do this one. Now we're going to do LCL, and I'm going to push out to test the lateral collateral ligament, and I'm going to pull in on the ankle. So again, fully straight. We want to unlock the knee, but we don't want to go down to here because you'll get a heck of a lot of laxity. Unlock the knee, and then varus stress. Same thing. Grade 1, some pain. Grade 2, there's a little bit of laxity, but a good endpoint. There's not stopping. And grade 3 is just really opens up, and I got some video that I'll show you with this. it's very important for these tests to do a side-to-side comparison. Some people are super tight, everything is like locked in. Again, make sure you're testing to see how relaxed people are, but some people are super tight and you get no motion. Some people are really ligaments lax, and the first sign will be that they hyperextend like crazy when you're doing the range of motion test. So check side to side, because you'll be like, you just check one leg and you're like, oh my God, your lateral collateral ligament is torn, and that's just the way they are. Especially people that are a little bit varus, they have some laxity. So side-to-side comparison is key. Okay, so then last thing you do, so you check both legs, compare them, and then, actually, let's show you this just for a second. Since I'm doing, no, we'll do the Lachman's, and I'll show you some abnormals really quick. Lachman's exam, same thing. You want to bring the knee up to 30 degrees. The reason why I like this drop Lachman's test is that I can free up my hands to do all the work and leave the foot as this. I know it seems like I'm riding a horse, but this is why I wear pants in clinic, because it would be very awkward if I wore a skirt. So this allows me to have hands free to do the most important part of the exam, and the patient tends to relax if I'm holding the leg up, and then I can check with my hand, make sure her hamstrings are relaxed. If this isn't budging, I'll tighten up a little bit. If this isn't budging, I can't get any motion. So I keep going, relax, relax, especially the accountants. They take a little while. Okay, so then, all right, so I take my strong hand in general and I put it on the femur. So in the small groups, you're going to get to try this. And the best thing about this exam is that Kristen can give me feedback if I'm learning how to do the exam on whether I'm doing it the same as the instructor. So we'll be able to do this in the small groups. So hand on the thigh, holding the femur still. And then I take my hand behind the tibia, and you hopefully be able to almost see the stop. It's quick. It's not rip the leg off. This is what the residents do when they're first learning, because that creates a lot of motion and you can't really feel any difference. It should be quick and you feel a stop. You feel it? Okay. So in someone who has an ACL tear, you'll feel about 1 centimeter translation. You'll feel a mushy endpoint as opposed to that hard stop, because the ACL is stopping the tibia from moving forward. So that's all the difference is. So, but the main key of it is just 30 degrees of flexion. Hold the ankle between your legs. Make sure you have a good endpoint, and check side to side. Again, people will have a little bit of a side-to-side difference. Some people have super tight knee. You'll hardly feel any translation. Some people will have a little bit of laxity before that ACL comes to its endpoint and stops. Sometimes if there's a side-to-side difference, it can be that they have a partial tear if they have an endpoint. But if in a complete tear, you should feel a side-to-side difference. So, okay, let's go back to, so this is a positive Lachman's, the drop Lachman's. You can see the translation. Okay. I already did the pivot shift, so I won't do that again. Got out of sequence here. Okay, varus stress test, like we talked about. This is someone who has, oops, sorry. It's one of my Cal soccer players that get grade 3. Everything was torn off the lateral side of her knee from an ugly tackle by someone from Santa Clara. I don't know why. I thought I fixed that video, but okay. Dial test we'll skip over. MCL injury, same thing. And that's someone, you can see the dimpling, kind of a grade 2, and then that's someone with a grade 3 where it looks like I could run out of the room with the tibia. So, okay. All right, we're done.